বলবেন। Abdul, can we start?
No, I'm বলবো তুষার ভাই, আমি বলবো।
Okay.
Proceed, please. Dear moderator, you can start your talk just after 10 seconds.
Okay. Assalamu alaikum and good evening. Welcome you all in today's presentation. Today is our 76th lecture, and today our speaker is Honorable and respected Professor Chowdhury H sir. He will deliver a speech on case studies in Ecg. Before start of the lecture, I'd like to request Professor Abdul Chowdhury sir to introduce again Chowdhury H sir to our audience, and then we proceed to the lecture.
Dear audience, I think Chowdhury H do not need any introduction because for last 2 years he's very much known to us. What I will tell you, he's a very fun-loving guy, and whenever he is there, the whole academic environment become very enjoyable, and that's the most important thing. How you make very critical things enjoyable, attractive, and eager to. It shall make you eager to learn more and to keep in touch with that person, and that personality is our favorite Hafiz Bhai. Hafiz Bhai, you are always welcome, and we are really grateful that you are always with us. You can start now.
So now I'm trying to, let me see.
Or just official announcement. Hafiz Bhai is clinical professor of medicine, University of Nevada, School of Medicine.
Okay, so nope. Screen shares. So
Sir,
can you let me share the screen?
এখন আসে নাই।
স্যার আপনি প্রথমে যেভাবে করছিলেন ওটাই দেন স্যার, হয়ে যাবে।
আসতেছে এই তো চলে আসছে।
হ্যাঁ আসছে স্যার।
No, but this is not the one. My okay, one second.
হাফিজ ভাই যখন ঢাকা মেডিকেল স্টুডেন্ট ছিলেন তার নিয়ে অনেক গল্প আছে। তো বলা হতো যে উনি নাকি রিক্সায় চলে এদিক ওদিক তাকে অনেক কিছু পড়াশোনার জিনিস খুঁজে পান।
আমার আসে নাই না?
এখন আমরা দেখছি ইসিজি বেসিক বিয়ন্ডের ইয়েগুলা।
এটা আসছে,
স্ক্রিন দেখতে পাচ্ছি
এখন আসছে।
ও না, ওপেন করেন,
একটা ডাবল ক্লিক করেন স্যার।
কিন্তু আমি তো ইয়েতে দিছি, আসে নাই। আমি তো প্রেজেন্টেশন মোডে দিলাম।
না আসেনি, ফাইল ওপেন হয়নি, লিস্ট
ফাইলটা ওপেন হয় নাই এখনো।
হাফিজ ডাবল ক্লিক করো, ফাইলটা ওপেন হয়নি এখনো।
শেয়ার স্ক্রিন,
আপনার ফাইল এক্সপ্লোরার শো করছিল।
একটা সেকেন্ড, সরি।
আচ্ছা ভাই, হাফিজ ভাইকে নিয়ে কক্সবাজারে একটা প্রোগ্রাম করা দরকার।
আচ্ছা, আমার মনে হয় ডিসেম্বর তো আমরা একটা ইয়ে পাবো আর কি।
একটা সেকেন্ড দাঁড়ান।
Oh, Baski, you are here. Thank you.
Yeah, hi.
Oh, Professor Maskid,
Hi. After
how
a
are
long
you?
time. I'm fine.
Yeah. So
Yeah,
do you see my
Yes.
EKGs now?
Yes.
Yes.
Yeah. Yes.
So what I'm going to do, I'm going to give you this overview about some cases. So it is a free floor for me. So, and I'm thankful to the to Atahar Bhai and Wadud. So show us anything. So what I did, I collected the EKGs for this last week and presenting those. But before that, I pick up some board questions. So these are from the board questions on EKG and how you look at this EKG. And I would request you not to go for diagnosis. Maybe this is a mixed audience. We have faculty here, we have residents, fellows, and also we have, I heard from Cox's Bazar, there is new intern joining soon. So this is a ECG that has tachycardia. Start with that. The QRS, you can obviously see, and the RR interval, you can look at, this is irregular. So this is more than 100 per minute heart rate, and the RR interval is irregular. And then you don't see the P wave. So there is no PR relationship. So if it is irregular heart rate, then only few are the differential, which is atrial fibrillation, atrial flutter with variable block, multifocal atrial tachycardia. But you don't, in atrial flutter, I'll show you like this one, you have the atrial depolarization, and you can see that there is RR interval regular, but the P wave is what we call sawtooth appearance, meaning it is crossing the baseline. And therefore it is atrial flutter 2-to-1 block. And the relationship of the atrial flutter to QRS is that every 2, there is 1 depolarizing the ventricle. So first question, tachycardia or bradycardia. Second question, is the QRS regular RR interval or irregular RR interval? If it is irregular, is it a regularly irregular or irregularly irregular? And then you figure out where is the P wave and what is the morphology of the P wave. Is it replaced by fibrillatory wave, replaced by the flutter wave, or it looks like atrial depolarization, but it is too fast. So it is atrial tachycardia. So, and then you look at the QRS wide or QRS narrow, and then the ST elevation or ST depression and any typical pattern. And of course, if the EKG looks like normal, the killer in the board question is that are the intervals normal? Intervals means the PR interval, the QT interval, all these are okay or not. So this EKG will be overwhelming to you if you look at this EKG and try to go to the diagnosis. But take it apart. In the left-hand side versus right-hand side, the left-hand side looks bad. The right-hand side looks worse. So the left-hand side, you can say that the QRS, if you look at lead 1, lead 2, QRS is narrow and looks like regular, but little over 100 heart rate. And there is lead 1 ST depression, lead 2 ST elevation, and then lead 3 more elevation. And then you look at lead AVL is elevated, and then later part, the patient goes into ventricular fibrillation. So this one, even it looks like almost like a pulse oximeter rather than EKG. And I tell them that when the pulse, the EKG looks like pulse ox, then it is a problem. If I tell you that this is on the top of the EKG, very faint, I wrote end-stage renal disease, dizziness, and lethargy. So any idea what it will be? Like our young friend from Cox's Bazar, Dr. Tizmur Rahman, if you want to jump in, but I'm just saying that it is your day 2 of your internship, and the patient on dialysis comes with this EKG.
Marufa is raising hand. Marufa Rahman.
Yeah.
Kamrul, dekho. Marufa Rahman is raising hand.
Hello, assalamu alaikum, sir.
Yeah.
Dr. Marufa, can you please introduce yourself and then answer the ECG?
Sir, I'm Dr. Marufa Rahman from Medical College for Women and Hospital, Uttara.
Good.
Oh, okay.
Marufa, তোমার কি মনে হয়?
Sir, যেহেতু patient is CKD patient, maybe hyperkalemia is the
Absolutely.
cause.
Right. So, I mean, you can see that the RR interval, it is a tachycardia, and the QRS is wide. RR interval is regular, but QR is way too wide. So, is it ventricular tachycardia and then wide complex, but it is like hyperkalemia, and these patients, if not treated, will go into Vpw, you know. But similarly, if you look at this one, that is wide, but this is also wide, right? And if I tell you that this is a 25-year-old young nurse had pre-syncope, then if you take it apart, that the QRS is wide, it is almost tachycardia, like little over 100. And you look at this P wave and the QRS. Can you see the P wave? Yes, in lead 1, you can see the P wave, right? And then QRS is wide, and it is sinus, and then little tachycardia, wide QRS. The patient is getting syncope, and the nurse, and you need to know the typical pattern of this can be present in tricyclic antidepressant poisoning. On the other hand, you know, this is our patient in the hospital, and 36-year-old with pancreatitis, abdominal pain, and the intern on that service talked to our intern in cardiology. He said, this EKG, what do you think? Do we need to do anything? Any idea? Because this is QRS, the R rate is normal. So not tachycardic, not bradycardic. RR interval is regular. We can see the P wave, and the P wave is very close to the QRS, and there is slurring of the QRS in the ascending limb of the QRS. And this is a typical pattern. When we see this kind of EKG, we call that Wpw pattern. Question is, what do you do for these patients? When in the context of this, will you do anything?
Has he got any history of syncope?
So the patient doesn't have any. So clinical history is always clinical. Any palpitation, dizziness, passing out, or feeling dizzy, any family history of sudden cardiac death, any congenital heart disease. All these are important, right? But if it is not, then we call it asymptomatic Wpw. When I was growing up, there was a myth that even in asymptomatic Wpw, you can just sit tight. But now we realize that there is association of this Wpw with structural heart disease, Ebstein's, congenital heart, and transposition of the great vessels. But that is very rare. In vast majority of the patients in Wpw, they will not have any congenital heart disease or a structural heart disease. But if they develop this palpitation and arrhythmias, such as here in the B middle panel, you can see that there is loss of ventricular depolarization, right? So that means that the ventricular pre-excitation is very quick because the PR interval is short. But when you see that patients get this fast heart rate, and then this pre-excitation goes away, but it comes during the time of tachycardia quite fast, like in C, then there is a vulnerability of these patients going into ventricular fibrillation. So how we identify that? Because in our time, it was myth. I don't know, Aziz bhai, you can jump in and make comments. So if it is not symptomatic, don't do anything. But remember, in a small number of these patients can present as the palpitation and syncope. And it is our job to find out who will be at high risk. You can do an echo.
I can make a comment on that. That's important to really recognize asymptomatic with Wpw or not. I think best thing what we do, we bring them patient to our lab, let him walk on a treadmill.
Yeah.
Okay. And if you see that like delta wave that we see, it gets better. And sometimes it just goes, it doesn't get worse. That means they are conducting more through the AV node rather than through the bypass tract. If they conduct more through the AV node, when they exercise and you don't see any abnormality, they are much safer condition than patient. And if you see widening of the QRS or delta wave getting worse, that means they're conducting more through the bypass
accessory
tract.
pathway.
Those patients are more risk. Then we need to take care of them.
So in example of B, you are seeing that the patient during exercise, there is loss of ventricular excitation, and the patient is going into sinus tach fast rate. So this patient is better off than the C, where there is very short pre-excitation. And as there is adrenaline surge with exercise, that pre-excitation pathway is used for ventricular depolarization. These patients are vulnerable for going into catastrophe. So you then propose for ablation. Now, this is an algorithm. You can look at this. This is a JAC, Journal of American College of Cardiology, February this year. And you can read this, the Wpw and how to proceed with the workup if you find asymptomatic Wpw pattern in the EKG. And I would request you, all of you who are doing internship, residency, or fellowship, that in our time we had this thing called Osar Bolse, so we follow that. In our program, for example, any faculty cannot just round, because everything has to be corroborated by studies or publications. So it really, and the culture may be different. Here they ask us questions, and that's why I like to be with the young people, because old people, they don't ask questions, they follow. The young people, they have a query mind and they ask questions. So always ask questions and convince yourself that why you want to do that. So asymptomatic may not be asymptomatic after all, because look at this patient. In the same week, I got this patient, 40-year-old, subdural hematoma, and he failed and sustained head injury, works as a Metro police officer. And then when he passed out, somebody noticed that he has tonic-clonic seizure and said, this is all brain, but brain was okay. But what happened, this is his EKG. Looks familiar, almost like sinus bradycardia, but there is the short PR and then delta wave in the ascending limb. Dr. Rafique bhai is not here, I'm missing him, but he will go through this delta wave, and then where is the depolarization, what is the delta wave axis, and then figure out what is the right atrial, or this is left atrial, left-sided accessory pathway. But it doesn't matter, because as Aziz bhai pointed out, we need to figure out what accessory pathway can kill you. And therefore, you need to study them and find out. This patient, for example, now if you look at the EKG, that passing out and head injury was not like a seizure epilepsy. It was a cardiac event, and we studied, and then we look at the EKG from before he was in our system. So it was concealed and then became a revealed Wpw that needed further study. It was interesting that this week, only day before yesterday or 22nd, New England Journal of Medicine presented this EKG case. And I was like curious that what is in it, that they wanted to focus, because many in this group will recognize the EKG on the left. This is like a 58-year-old coming with chest pain. We all have gone through this so many times. The Wallens, right? But why NEJM published this? I was curious. And then I realized that they published it because the patient had a delay in the procedure and then subsequently developed this. And this is called the triangular type ST elevation, or in many ways you can call this the so-called shark fin ST elevation. And this is very poor prognosis when that happens. We actually looked into this and published from our institution, going back and finding out this ST elevation morphology, and we realized that this triangular type or shark fin pattern EKG has a very high in-hospital mortality, hemodynamic instability, and they go into cardiogenic shock. Now,
1.4%.
Yep, it's a very, very important thing that NEJM reported for that reason. That patient actually is from Japan, and they did the LAD intervention and patient did well. So this is another interesting patient. Is one of my partner's patient came into the emergency room with this EKG. So I tell you, I would not get intimidated by this EKG. The problem that vast majority of the resident fellows and interns, they get, when there is abnormal looking EKG, they get intimidated. So take it apart. Is it tachycardia or bradycardia? Ask yourself. It is tachycardia. When I say tachycardia, I talk about R tachycardia, meaning ventricular rate is high. And whatever you feel in the pulse is the pulse rate. But whatever you get from the heart, it is the heart rate. Sometimes the pulse rate can be lower because of the AFib, and you call this pulse deficit. But when you see the QRS and the RR interval, the QRS rate is faster than 100. And it's almost like 160, 170, right? There is a magic number in tachycardia that the EP doctors do not want to listen and do not want you to say, but I say it anyway. And this is the fun part that I like to do with Rafique Bhai, that if the heart rate is 280 to 320 atrial rate, then the ventricular rate becomes half, 140 to 160. So when the ventricular rate is 140 to 160 range, then you always make sure that you entertain that there is atrial tachycardia or atrial flutter in the differential. Atrial tachycardia will be lower. That means 220, 240, 260. But when it's 280, you are in the flutter range, atrial flutter range. And usually that's the find in the EP study anyway. So here, the problem is it is little faster than 160. That means you are not in the atrial flutter range. You are like 170, 180. That can happen in atrial fibrillation. If you get ventricular rate 190, 200, and young patient, you should definitely think that there may be a ventricular pre-excitation underlying. That is very bad, problematic. And if you may not see the narrow complex or wide complex as clearly as you may want. But when the rate is so high, you need to be careful. But in any case, if it is narrow, that means the QRS depolarization, ventricular depolarization in the orthodox pathway, meaning AV node, the His bundle, Purkinje system, and through the Purkinje system, muscle to muscle, the QRS is narrow. If it follows one of the bundle, then it called the delay in that bundle cause the bundle branch pattern. So the left bundle branch block is a misnomer. Left bundle branch delay. That means left bundle is delayed. If left bundle is sick or for some reason is not transmitting well. So similarly, if the excitation goes from the atria to the ventricle through the pre-excitation pathway, it does not find the orthodox conduction system. It then goes muscle to muscle. So that will be antidromic depolarization of the ventricle, and the ventricular rate will be faster, but the QRS will be wide because of the muscle to muscle conduction. And in this case, for example, if you look at, there is a right bundle pattern in V1, but the bottom line is that this is tachycardia, RR interval is regular, and the P wave is difficult to figure out. It can be present in 2-3 AVF, but I cannot tell that this is obvious P wave or maybe looking like P wave. So what to do? The emergency room physicians, they gave adenosine, but then it revealed the P wave, but it did not convert, of course, because if it is AV node dependent tachycardia, such as AV nodal re-entry tachycardia, the adenosine will block the AV node and then it will break the circuit. But in this case, it did not break the circuit. And the patient, look at this, the patient's pulmonary arterial pressure is 100. RVSP is 100. RV is humongous. So what will be the likely diagnosis knowing that? The baseline EKG shows the right, the sinus rhythm and then right ventricular hypertrophy. And this is the echo, severe tricuspid regurg, RV dilated, and RA is huge, right atrium. So will you change your diagnosis after knowing all this? That what will be the most likely rhythm on this EKG? So this was a atrial tachycardia. So there is implication in terms of how we manage this narrow complex tachycardia. If it is AV node dependent tachycardia, then we give medications that control or work on the AV node. Otherwise, you give atrial tachycardia, give something that affects the atrial tissue and lowers down the heart rate. So this is another patient, 64-year-old, diabetes, subdural hematoma, bipolar disorder, and has this rectal bleed, and anesthesia got worried about this EKG and told us that call cardiology before we do further scope. So what do you think? The heart rate is little fast. So it is 105, 108. Heart rate is, and the RR interval is regular. And then it shows a pattern. And the pattern is left bundle. And if you look at the all leads, you look at the 2-3 AVF is the best lead to find the P wave. And here you go, in lead 2, you can see the little blip, the P wave. And the PR interval is normal. So this is actually sinus tachycardia with left bundle branch block. So for in a young patient, otherwise no cardiac history, from the Framingham, we know the left bundle has independent prognostic implications long-term, but the right bundle does not. Once you can show that there is no underlying structural heart disease, but left bundle, that is not true. Over time, there may be manifest in cardiovascular diseases in this group of patients. We know from the long-term Framingham study. Interestingly, if I tell you that that patient had this EKG a couple of months ago in the same hospital, what will be your diagnosis now? This is before, and now this is, and then one of the residents saying new right left bundle, so it is a ST elevation MI. Dr. Maski, how will you handle that? Because we had to go through this pain, you know.
Yeah, I mean, we get a lot of cases of intermittent complete left bundle branch block, and you do all investigation, you do not find any cause.
Right.
So we'll have to look at the history of the patients and go through his echo and find out what is baseline ejection fractions. And if the patient is doing fine, don't treat ECG, you should treat the patient.
Yeah.
And we get a lot of this sort of cases quite often. And
So
this is problem with the anesthesia, I think.
Let me tell you, repeat what Professor Maski said. Don't treat EKG. The STEMI, ST elevation and MI is a clinical part. ST elevation is EKG part. And this ST elevation, even if it is looking like ST elevation, which is not, it looks like left bundle. The question is why there is left bundle suddenly when the EKG was okay. It's most likely rate-related left bundle in this case, but we did do an echo. Patient doesn't have any symptom whatsoever to suggest MI. So we assured them and the patient went for the endoscopy and no problem. So, and the fellows, of course, invoke other things. That one fellow said, even if it is new left bundle, it does not fulfill the Garbosa criteria. True.
Yes.
But I don't even look for that if the clinical doesn't make sense. And the Garbosa, you can look into these 3 criteria. If you have 1, your sensitivity is high. But if you have 3, your specificity high, your sensitivity may go down. This is another EKG. This is interesting. 79-year-old with fatigue for 2 weeks, went to Mexico, came back, and a history of bug bite on the abdomen. But the EKG is this. So following that, heart rate, this is bradycardia. Heart rate like 1, 2, 3, 4, 5, 6, 7. So almost like in 40s, right? The heart rate, bradycardia. If you look at the morphology, the QRS looks like right bundle. The QRS axis looks like left axis. We can see P wave, and I would request you that to measure the RR interval, please use calipers or a piece of paper with markings, so that our eyes sometimes can be fooling us and may not give you the right regularity. So RR interval is regular, PP interval is regular, but there is PR, P and QRS relationship is variable. That means there is no relationship. So looks like the ventricle is contracting on its own pace and the atria is contracting on its own pace. And if you look at the neck of the patient, there is a cannon wave because of contraction of the atria against the closed tricuspid valve, and there is large wave, we call it cannon wave. The complete heart block actually was diagnosed before the EKG by clinical. And that was the concept that there is AV dissociation. AV dissociation means that the atria and ventricle not talking to each other. But if there is a RR interval regular, PP interval regular, atrial rate higher than the ventricular rate, and there is PR dissociation, then it is complete heart block. But it can be opposite for a second. Think about it. If the ventricular rate is high, and then it is like 130, atrial rate is 80, and then the ventricular AV dissociation, it can be present in ventricular tachycardia. So AV dissociation can be present in ventricular tachycardia. AV dissociation can be present in heart block, complete heart block, but the atrial rate in that case higher than the ventricular rate. And then patient got the pacemaker, of course. What about this rhythm? And I would not put you on a halt, on fault if you are not getting the diagnosis right. Give me a differential. So RR interval regular, and the RR interval is within 60 to 100 heart rate. If it is within 60 to 100 rate, then neither tachy, neither brady is normal heart rate. And then there is P wave, very clear P waves in 2, 3, and AVF lead. And we can see the PR interval, and the PR interval is fixed and it is not variable. So it is sinus, the P axis 2, 3 AVF all upright. So P axis is normal. So it is not ectopic atrial rhythm, it is normal sinus rhythm. PR interval is normal, and the QRS looks like left bundle type. But the patient actually had a pacemaker, it looks like a pace rhythm. But if Rafique bhai was here, I would say we pass both. Yeah.
What I say sometimes, look at ECG, you get Wpw pattern in the limb leads, but you do not get any wide QRS in V5, V6. Then look at the proximal part of the QRS. Is there any spike?
Yes. Yes, absolutely. And then what about this one? This patient had alcohol abuse, previous stent in the coronaries, and stroke. The reason I say, because if you think that this is stroke and you diagnose AFib, the therapeutic implication is huge. You cannot just say AFib and then that will generate a whole host of downstream workup, and also you may end up giving blood thinner and patient may had a bad complication and death with bleeding. So this is regular rhythm, heart rate little over 100, little tachycardic, and the RR interval is regular. So it's a regular sort of tachycardia, and only in the rhythm lead at the bottom, you can see a little blip after the QRS, but cannot tell. See, in this situation, best thing to do is give a differential. Like, is it AV nodal tachycardia? But it's not that slow. AV nodal tachycardia is really faster than this, 180, 190. Atahar bhai, any comments? Or AV tachycardia, AV re-entry tachycardia, usually faster. It can be atrial tachycardia. It can be atrial flutter with 2 to 1 block, but the atrial flutter is slowed down by medication, possible. So these are few differential. Atahar bhai?
Yes, all the differentials are acceptable, but most likely you have to, what we give the stress about the ECG, that is the finding of the P wave.
Yeah.
So this is the moderately wide QRS complex. the QRS progressions are normal. But if we search for the P wave in the lead 2, which is one of the good lead for the P wave, just after the QRS complex, there is a just blip, that is the negative blip after the QRS complex. Maybe this is one of the P wave. And we can also think about the V2, just before the positive blip, likely maybe a P wave. So the most consistent lead is the lead 2. That is the negative deflections after the QRS complex. Most likely that is the inverted P wave. And if it is true, then it is the AVNRT most likely.
But the rate is very slow though. And the patient was not on medications. So, and then baseline EKG showed this. So we thought that this probably could be junctional tachy.
Yep.
And the patient with the correction of blood transfusion and potassium and phosphate correction came down on its own because of the heart rate was not that fast. And then we got the patient back in sinus. And the life may not be easy because you may have bad tracing like this one. If you look at that patient with the little blip, and this is the part I make fun with the EP guys, that they find P wave that we'll never find. But you will hear from Atahar Bhai that where to look for the P wave. So here it is tachycardia, right? It is tachycardia. And then is it regular or irregular? So be careful. This one in the middle part looks like regular, but if you look at take your eyes in the left corner, right corner, you suddenly realize that this is actually irregular in the corners, right? So it is better to use slide calipers and also use, or if not, then use your paper and then actually manually check the RR interval. Any comment on this? So the RR interval is irregular, but now you decide whether tachycardia, narrow complex, looks like a right bundle pattern in the V1, but the P wave, I think we can see, and sometimes we are not convinced. But if you see it, you'll have to ask yourself, is it an organized P wave or totally chaotic fibrillatory wave? If it is fibrillatory wave, AFib. If it is organized P wave, then we'll have to respect that P wave. Is it fluttery type or it is atrial type? Because that will determine the diagnosis. Any comment, Atahar Bhai?
No, for such kind of the irregular QRS complex, the first possibility is always is the atrial fibrillation, but there are few beats that is preceded by the just like the P wave, that is the 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. There is the 11th leaf on the rhythm strip. There is some deflections before the QRS complex. Maybe a part of the QRS complex or maybe a part of the P wave like this. But such a kind of the isolated P wave in a single does not convince the differential. So first possibility is the atrial fibrillation. Definitely.
আপনার যেহেতু আপনি ডাউট করতেছেন, একজন ইপি ডাক্তার বলতেছে যে দিস ইজ মে নট বি এ ফিব, আমার রিকোয়েস্ট যে লেটস লুক এট দি ক্লিনিক্যাল স্টোরি, স্মল সেল লাং COPD. Yes,
can I add something? In atrial fibrillation, regularly at the ST segment, this deflection is very unlikely. It's every beat has one deflection at the end of the QRS complex, just after end of the QRS. In atrial fibrillation, it's very unlikely.
Correct.
And to me, it seems.
Jamil bhai, apni give up karen na. Apnar faculty commenter aage, I wanted to let everybody look at the clinical presentation, and this is one of the things that I always believe that this forum's name EKG and beyond, basics and beyond. When you figure out the basics, then look at the clinical presentation. And then following Atahar Bhai and Jamil Bhai's lead, what do you think the alternative diagnosis? Because the faculty is not convinced that this is AFib, because they are saying they see P wave. But I'm telling you, look at this history, COPD, lung mets, previous history of cabbage, heart failure. What do you think? Possibilities. It can be possibility that it could be atrial tachycardia, atrial flutter. And in a COPD patients, atrial tachycardia is not uncommon. And if it is atrial tachycardia, the explanation is that it is probably multifocal atrial tachycardia with variable block.
I have one comment on that. The reason is I see some retrograde type P wave. You know, that's my concern, because in multifocal atrial tachycardia, normally they're long RP tachycardia, not short RP. So that's my concern. This is a short RP tachycardia. And I know that my first thought was with the COPD was multifocal atrial tachycardia. I would see at least 3 morphology, and also they are long RP tachycardia, but this is definitely short RP tachycardia. Along with that, some ectopic beats I'm seeing, and the origination, where it's coming from.
Yeah, we will.
That's my comment.
Unfortunately, we'll never know because the patient died. But what I'm trying to tell everyone that you can give a differential and then work on the differential, and the patient will be still safe and properly treated. It is possible that it is possible that it is multifocal atrial tach with variable block. So if it is multifocal atrial tach, you have the obligation to prove that the atrial depolarization morphology changing. But if it is atrial tach with variable block, it's just a variable block. But Aziz bhai, apnar point well taken that it is not a long RP. However, Atahar bhai is here that it is not short RP either. This is not short RP. It doesn't look like short RP. So,
sir, basically what Adit sir said is right, because if we consider short RP, the R2P and P2R, R2P is quite shorter than the P2R. So per se, that is short RP. And another thing that Adit sir mentioned is that in case of multifocal atrial tachycardia, the P wave, the presumptive P wave must be before the QRS. The QRS will follow the P. Whatever the morphology of the P, the QRS will follow the P.
So
in this case, the P is following QRS.
Right. So one problem with the multifocal tachycardia. Yeah, Wadud.
For our young fellows, young audience, remember that whenever you get such type of ECG, relatively narrow complex, irregularly regular it seems, go for the basic diagnosis. Say it's atrial fibrillation. You won't be much wrong, because COPD patient who also had coronary artery bypass surgery, they're very likely to have atrial fibrillation. And you are not going to do much harm to the patient.
Correct. Yep. That's very well said. And the other thing is that we sometimes go and argue that who is right, who is wrong, but just give a differential and accommodate all the differential, you'll be fine. And I can't tell you how many times even the EP docs said one thing to us in the lab, they find something different and then tell, oh, we find interesting. So this one is a challenging one. I tell you why. This is a patient, 76-year-old, body mass index was like 37, big guy, 15% EF, and came in with rectal bleed, and the hemoglobin dropped, and the emergency room doctors, they told us this is STEMI. You need to admit this patient and do cath. But we found this in later from the same hospital medical records. three things you need to ask in the history taking. And this is, I call it non-negotiable. Ask the patient why the patient is in the hospital. Number two, did you have any cardiac procedures before? Stent, bypass, pacemaker, ICD. I have made this rule because I'm fed up that people do not look at the records. And then, have you been in the hospital before? And which hospital? Look at this and then go for electronic medical record, click that whether there any admission anywhere, because that will help a lot. And then exam, look at the scar mark and then any pacemaker or anything. Pacemaker ICD means that somebody has visited this patient before, and you get a lot of clue, because we pose our patients at risk by not looking into this and rush to the cath lab, and the disasters happen. So with that note, what do you think this patient has? Tachycardia, correct? Because the patient's heart rate is faster, right? And then QRS is wide. Yes? QRS is wide. And do you see the P wave? That's the problem. Heart rate is like 130 range. QRS is wide, and the P wave we don't follow. So it is a wide QRS tachycardia, wide QRS tachycardia, and no P wave. Question is it too wide? Is it too wide to call it VT, or it is intermediate wide? I think Rafique Bhai will shoot me today if he sees me teaching like this. Because there is a set criteria for identifying VT, which is, do you see any capture beat? That means a normal beat in the storm of the VT, or a fusion beat. That means a fusion of atrial and ventricular depolarization wave in the middle of the VT. You don't see any of the capture with fusion beat. And there is other algorithms, the Brugada algorithm, that, what is the depolarization time, the early depolarization time from, is it narrow or wide? And do you see the S wave in the V6? All these are there, but I'm giving you a very simplistic version, which is wide complex tachycardia. If somebody tells me this is wide complex tachycardia, I'll let it go, particularly an internal resident. And in the presence of a coronary artery disease, wide complex tachycardia is BT until proven otherwise. And look at this. This patient had further run like this in the floor. And if you look at this, that you want to comment? Atahar Bhai, further comment?
No, the telemetry is in favor of the VT.
Yeah.
That is sinus rhythm followed by the wide complex tachycardia, initially slow but getting faster.
Yeah.
And finally,
and the pacemaker, the ICD tried with the ATP, and then finally shocked.
Exactly.
Okay, so with that, let me tell you another patient. I think we have time. 41-year-old coming with dyspnea, troponin normal, and this EKG. And he says that I don't get shortness of breath, but sometimes I get extra heartbeat, and then that makes me really bothered. And I feel short of, like fatigue, short of breath. Question is, if you look at this, there is an abnormal beat coming, right? If you look at the V5, V6, the one beat looks like normal, followed by a very different axis, different QRS looking and wide. And there is a compensatory pause, if you look at. So this is PVC, premature ventricular conduction. And question is where it is coming from. So we thought that this is coming from the right side because it's a left bundle pattern. And question is, this young guy, what to do? So because of the hospitals, like I don't know who created this pathway, he believe it or not, Aziz bhai, the patient was ordered a Lexi scan. The Lexi scan was normal, of course, but we did a treadmill, and this is the treadmill, and look at this. In the treadmill, patient did this. Patient needed an exercise test to see
Short
runs of
RVOT probably.
Successive PVCs. And if it is more than 3 or 3, and then heart rate more than 110, then by definition, this is non-sustained VT. But the VT is ugly looking, isn't it? And then getting worse. So he had short runs of non-sustained VT. We did angiogram anyway, because they wanted make sure there is no anomalous coronaries, and then our echo was normal, but patient will be going. Our differential was, as Aziz bhai pointed out, could be RVOT or RV scar related or arrhythmogenic right ventricular dysplasia. Looking at the EKG baseline again, there is no epsilon wave in the V1, but it is also possible that this is catecholinergic polymorphic VT, looking at the morphology of this. So 51-year-old, no past medical history significant, came to the emergency room and then had this EKG. Sinus rhythm, right bundle, right? And sinus tachycardia. So they called it ST elevation. We did not see any ST elevation anywhere. The 2-3 AVF, lead 3, it is a part of the QRS complex mimicking like this. And believe it or not, the bedside echo was hyperdynamic LV. So nothing was done. 92-year-old mechanical aortic valve, it should be biologic tissue valve, and then had an ulcer. INR was elevated, but look at this EKG. After the hemostasis made post-op, the patient did this EKG. Sinus rhythm, long PR. By the way, following the rule, there is bradycardia. RR interval is slow. RR is regular. If you map this regular, and then we can find the P wave. The P wave are regular, and the PR interval is prolonged, but the PR interval is fixed. So this is first degree AV block, right bundle, and left axis deviation. If you look at the 3 AVF, so the electrophysiology doctors, they don't like this term trifascicular block. Because I think in one way I agree with them. That means the AV conduction is slow. That means the left anterior fascicular conduction is slow. The right bundle conduction is slow. There is no block. Nobody has blocked the conduction. It has made it slower in an elderly patient because of the degenerative disease and conduction system disease. So this is the so-called trifascicular block. And these patients, when they go into procedure, they have a higher chance of going into complete heart block. So you need to assure them. And interestingly, this patient had a lot of aortic regurgitation and a bioprosthetic valve and some aortic stenosis. So if he survives the bleeding, we may think about TAVR. So this is another patient with subdural hematoma. And then it says, okay, no, I think I showed you this one. Let me show you this last case. I think we have 5 minutes. 61-year-old Armenian origin. and has a language issue, came in, and we were told that he was picked up by the EMS, not responding, EMS not responding, and then no pulse, shocked once, got pulse, intubated, came to the ER. Before they call us, ER already did the CT and CT head is negative. But this is the EKG. Shocked one time, and as we are looking at the EKG, the family now says he was having chest pain for last few days, at least 5 days, and this pain somewhat got better, and then he was in the dinner table and then collapsed, passed out in the dinner table, and they called EMS.
Dr. Tasbir হাত তুলছিল.
Oh, definitely.
Tasbir, you can talk, unmute and talk.
আমি তোমায় বলার পরে খেয়াল করলাম Wadud, there are a lot of good suggestions in the chat box, and I'm actually very happy that many actually got the diagnosis right and wrote nice notes. I can tell you the name of the physicians: Chitra Raj Sharma, Vishal Shrestha,
and they are students of Arun,
the great master.
Yeah.
Yeah, Arun, kudos to you. Great.
Tasbir, do you want to talk?
You can ask Vishal and Chitra if they are there.
Sure. We need to go to Nepal and meet your guys.
Yes.
Oh, no, Vishal is coming, Wadud.
Yeah, he's supposed to.
Yeah, because he got, just now he got VMDC and then processes now. He's looking for tickets and coming.
Go on, continue.
So the sinus rhythm, right? The RR interval is regular. The P is distinctly manifest. The PR relationship is good, right? But now the question is, the rate is not high. So it is normal rate, normal sinus rhythm if you look at the lead 2. But the main thing is the precordial lead. There is a very distinct pathologic Q wave and ST elevation. When there is distinct so much pathologic Q wave and the history from the patient's family, so this is what we call the queued out LV. You can see this in post-infarct period, and also you can see this in LV aneurysm, persistent ST elevation with the recent MI, and that is a problem, because rushing to the cath lab we might not see anything to salvage. But interestingly, look at the LDL of this patient. LDL is 147. It is a board question that following MI, immediately after MI in the hospital, the LDL actually is lower, and most people do think that this LDL goes high, the C-reactive protein and stress, but actually cholesterol is lower, LDL is lower. So if that is 147 after the post-MI, that means LDL is really high, and that needs to be aggressively treated anyway. But if you look at the echo, this is what we think actually was found. If you look at this, these are the regular transthoracic echo. We also did the strain imaging, and Asif will be interested. All strains in the apical area were bad. And then we did the contrast echo, and it looks like the whole apex aneurysmal. Although we did not rush to do the cath, and then subsequently we did, and the patient is, we tell this that by time, see whether there is any meaningful recovery or not. If neurologically there is no meaningful recovery, all these interventions and resources utilization are useless. So this is the futility of care if we rush and do things. Luckily, this patient came around, and then the LAD was bad. The RCA was chronic total occlusion with collateral flow. I'm giving very few views and few description because Rafique Bhai doesn't want too much on this, but the ostial circumflex is also bad. And then as you saw in the echo, there was a significant issue with the LV-gram with whole anteroapical inferior aneurysmal. So we were careful. We did the thallium rest redistribution. There was significant viability, except maybe the apex. So what should we do next? That was the question. I have slides, and I would request the faculty to go through their REVIVE study that published in ESC that shows viability guided did not make a difference. And you may be thinking that that is a negative trial, but a lot of things to discuss about that. But in this case, two problems. One, the question of revascularization, and two, the patient had a beefy arrest and what to do before discharge. So I will stop there, and maybe we can discuss and finish and wrap up. I think this is 1 hour already.
Arun, do you want to make a comment?
I mean, yeah, I joined after quite a long time.
Yeah.
This was the real case-based discussion requiring in daily practice. I mean, Ahsan Bhai is fantastic. He has been an excellent teacher, and he knows how to teach because he's involved with academic activities and board exams. These are the practical things I think we should all learn. That was very great.
Oh, thank you. So on that patient, we did I told our electrophysiology guys that this will be a secondary prevention, because if it is immediate post-MI, STEMI or non-STEMI for that matter, but if it is within 24 hours of the MI, STEMI, beefy arrest, and then it is primary VF, we revascularize, but we don't give the ICD. But this is a late phenomena, and the troponin we followed, it did not show the typical rise and fall. We were seeing the tail end of the troponin, and there is aneurysm. I argued that this is a secondary prevention ICD. And what do you think, Atahar Bhai? But question of revascularization, I told my EP colleague that even if I revascularize, I still think he should get the ICD. And that's the part, it's a little complicated, because if you both agree that PCI, surgeons don't want to do it because they said what to vascularize, it will be high risk, and they threw towels. So we did the PCI of the LAD, and then we negotiated that regardless of the PCI, it needs an ICD. Who goes first? So
one comment I'd like to make. The reason is we know that if after MI or peri-MI, like 48 hours, definitely any VT or something, we do not go for that. There's particular guidelines for that, particularly the Danish trial. So we have to wait a certain time. But my concern is definitely delayed VT. And as we understand, the question we have to define, this VT is coming from ischemia or from the scar tissue. Okay, if it is monomorphic VT, I'm not sure exactly, we didn't catch it, But if you see if the patient is on the monitor for 5 days for any reason, if there's monomorphic VT, most likely it's from the scar tissue. And that's not going to go away even if you vascularize the patient, revascularize the patient. It's still the risk because of the potential reentry in the scar tissue. Then they need an ICD. If it's after 5 days, then for secondary prevention, okay? And, but if it is ischemic VT, normally we see polymorphic, Vpw, those type of VT. If it is coming from the ischemia, then they revascularize, then they would have been benefited. Then patient might, we can wait, 90 days post revascularization and think about that. But it is most likely coming from the scar tissue, and patient would need ICD. That's my opinion on that.
So a couple of things. The rhythm is VF. So
okay.
if it is VF and shock, then it is VF is totally different category. Primary VF with the STEMI, revascularize, you don't need anything for VF. But if the VF happens after you fix the LAD, for example, and the patient went to the floor and then 2 days later had a Vpw arrest and the stent is open, then that patient needs secondary prevention. If the stent is closed, again, with the stent thrombosis, you open it and you say that that is related to the MI with the stent thrombosis. For the Vpw that is late in the game, which is like our patient, and for a patient in the hospital, you did the LAD, but Vpw happened because this scar-related PVC, VT, and then Vpw, then that needs ICD. For the VT, it's a totally different issue, because then we need to, as Asif pointed out, that it is sustained VT or non-sustained VT. If it is non-sustained VT, we do not suppress them. We do not give them amiodarone. We just treat them with beta blocker, and then we just watch and then correct potassium, magnesium, and then that's it. But if it is sustained VT, then monomorphic or polymorphic usually ischemic, but there is considerable overlap also. And then if it is scar, then you end up doing this ICD. One thing is the term primary VF prevention and secondary VF prevention is very important, because if I have a bad LV, you talked about the Dennis trial. In the Dennis trial, for example, non-ischemic cardiomyopathy, EF bad, but non-ischemic, then the ICD preemptively putting did not help. Mm-hmm. On the other hand, primary VF, prevention of primary VF, primary prevention. But if it is secondary, then nobody is going to accept that you watch. You have to give the ICD. I agree. Mm-hmm. Secondary VF is a class 1 indication for ICD.
Can I put in a comment?
Yeah.
Last case we have shown a Q-wave MI, antiseptal, and echo shows a big aneurysmal dilatation. Now, for treatment purpose, there are two things we have to consider. One, the patient will deteriorate in two ways. Either deterioration of the LV function, that heart failure you have to prevent by doing some intervention. And because of the big scar and big aneurysmal dilatation, there is a chance of re-entry and the chance of secondary VT and everything. And that may be improved by revascularization, may not be. And as the patient have one episode, and after not primary VF or primary VT, so you have to put an ICD. There are two prongs that will prevent cardiac arrest, and this will prevent heart failure. You have to use two hands of the interventionist.
Yeah, absolutely brilliant point. And that was my point to argue that the right coronary CTO, that was not the culprit. So if it is acute peri-infarct further prevention, then go after the LAD. That's where the big money is. And then bring back and do the circumflex. But I'm not going into that because that is an ostial circ. Rafique bhai will have a fit if I start talking about how to tackle that. But the patient did get a seat ICD. Yeah. And this is the thing. I don't know Atahar bhai, but our EP doctor colleague, he was okay. I did the aspirin Brilinta, ticagrelor, and he did the ICD on dual antiplatelet. Many EP doctors, they do not like to do that.
One question I'll be asking the faculties: which one will you do first, revascularize or the put in ICD first?
Patient is in the hospital.
Yeah.
Outpatient.
How often do you use?
What will you do?
How often do you use MRI viability in your setup?
MRI viability? MRI?
Yeah.
MRI we do, no, we don't do MRI for viability because we do, we are more used to do PET, 5-fluorodeoxyglucose PET.
So do viability, I mean, if that shows viability, and then try, if it's ischemic, then maybe that would be first revascularize, whichever you way.
In the
And
hospital, we did a thallium redistribution, 0 and 24-hour redistribution thallium. And the apex was not lighting up. So it was fixed in the apex. That means dead. The anterior wall, lateral wall, it did show a decreased uptake in the rest, but some reuptake in the late 24 hours. So there was some viability in that area.
And actually, Dr. Chowdhury mentioned that that the recent trial, that viability trial, was not very conclusive. But the question right now looks like if you have some amount of viability, even if you have big disease, big artery disease like LAD, that area, and if there's some always pre-infarctional ischemia there, always. Yes. You might improve with revascularization, and also that might further prevent worsening of the LV function. Definitely need to do guideline-directed medical therapy. But on the other hand, there's some data that even you revascularize that might improve. In this case, probably in that amount of disease, then I'd probably revascularize the main culprit vessel. Then I'd do the ICD. Because if anything happens during the cath lab, they can handle it.
But only reason to do the ICD first will be to avoid dual antiplatelet. But then the REP, yeah. So I think we stop there. Any other comments? I think we are on time.
Atahar bhai, will you make some comment, please? I see Professor Enamul Haq. He's a pulmonologist. Enam bhai, are you there? Enam bhai, he's a professor of respiratory medicine.
Actually, the ICU and arrhythmia in ICU, that can be a good topic to discuss. I think Rafique bhai or someone did in this forum once.
Exactly.
Arrhythmias in ICU is a very important topic, actually. And we need to work closely with them, with the pulmonary critical care. They are like inseparable part of us.
True.
Atahar bhai,
So,
will you
bhai,
wrap up
actually,
the session?
Yeah, congratulations, Chowdhury. Actually, this is a unique session today. This is a mixture of the basic plus beyond plus clinical. This was a trial from Professor Hafiz, and I think it will work. I think we and our students from the Coxbus and other, everybody enjoyed this session, today's session. That is the mixture of the basic plus beyond plus clinical. Thank you very much, Asif bhai, for your brilliant lecture today. And I also like to welcome Arun Maski.
Yeah.
After a long time, happy to see you, and we want to hear from a lecture from you, Arun Maski.
Okay, sure. I will definitely plan.
Okay, thank you very much for after a long time.
Arun, we are going to start from the basics again.
Okay.
The next lecture will be Atahar bhai. What will
Sir, Abdul Jamil sir. Abdul Jamil sir, normal variants in adults. Normal ECG variants in adults.
That's a killer topic.
Yeah.
Because normal is hard to say normal.
And I like to request Chowdhury Hafiz. I want that you will be ready every day. Actually, we and our students enjoy you very much. So
Oh, thank
when
you.
there
Thank
will be
you.
a gap, you please fill the gap. That will work as tonic, really.
I'm missing Rafique bhai because I usually attack Rafique bhai. Okay, thank you.
So thank you very much for your today's session, really.
Okay, and by the way, the good thing is that we went up to 85 or something. We dropped
100. 100. It was
but
100.
but
Yeah.
Tushar, good thing is that
It crossed century.
And there are
It touched century. Yes.
and there are also many bodies in the Facebook Live. So no problem.
good thing is that we have not dropped below 50. Let's close it before it falls below 50. Thank you.
Thank you. For
Thank
the
you, sir.
dear audience, next lecture will start from the very basics. So I hope all of us will be attending the next one. For the faculties, it will be just recapitulation. For the young interns and everyone, I do think you will enjoy the lecture. The different variations of in adults that are actually normal. And Dr. Abdul Jamil will be talking about it. And I hope we'll get beautiful comments from Ajit Bhai and Hafiz Bhai and Arun Maski in that lecture. And Maski, we need you twice monthly.
Yeah, sure, I'll be regular now.
With your team, Arun Maski, your teams are fantastic. They're very much academic.
So thank you, everybody. Atahar Bhai, will you finish it?
Yeah. Okay. Thank you, everybody. That is a good night, and hope to meet you in the Sunday after the coming Sunday. That is Abdul Jamil.
Okay. Thank you.
Thank you.
Today. Okay. Thank you very much.
Kamrul and your Beximco team, Nabila, thank you.
Sir. Okay, sir.
You
Thank
have
you so
been
much,
always
sir.
there. Thank you. Thank you very much. And good night, everybody.
Good night, sir.
Good
Good night,
night.
everybody.
Good night.